Hello everyone, this is Michael Abraham. Today I presenting the case for Mr. Richard Taylor. Mr. Artie is a 56 years old male, complains of depression, and he has a desire to take control of his life again. Mr. Artie had a COPD exacerbation in March of last year, which was treated as an outpatient with antibiotics and no need for hospitalization. 3 years ago, Mr. RT had a ST segment myocardial infarction. He was treated with PCI, including a drug-eluting stent, aspirin, clopidogrel, metoprolol, and atorvastatin. 1 year ago, his ejection fraction remains normal and at 57%. Mr. RT is presenting today with a sign of severe depression since his heart attack 3 years ago and has a depression mode for the past 6 months. He does not have any interest in his hobbies and constant feeling of guilt, fatigue, and worthlessness. He feels less inclined to spend time with friends and had trouble recently with ability to concentrate at work. Colder weather, holidays, and spending his birthday alone contribute to his overall feeling and make his depression worse. Mr. RT does not exhibit suicidal ideation or any symptoms of bipolar disease, mania, and anxiety or insomnia. 3 years ago, he treated with citalopram. It worked well for improving symptoms, but he complained about some side effects including erectile dysfunction and diarrhea. Today he need a treatment with something that does not cause these side effects. He is willing to quit smoking. He may start to exercise again and lose some of his weight if he can breathe better. He does not exhibit any sign of bronchitis with COPD, but does have symptoms of shortness of breath with walking and during exercise, but not at rest, which he limited his ability to exercise. Mr. RT is compliant with all of his medications. Mr. RT's AAT testing was unrevealing for alpha 1 antitrypsin deficiency. He vaccinated at last visit with Pneumovax 23 and influenza vaccine. He has abnormal mood appetite and he gained 15 pounds in the past 6 months. His blood pressure a little bit elevated at 138 over 86 and elevated liver function ALT 42, AST 47. His FEV1 FVC ratio is zero point 0.7. His QTC interval at 457 millisecond. His eosinophil count is 50. His CAT score is 21 and HAM D score at 16. So Mr. RT past medical history contain myocardial infarction December 2018 in addition to cholesterol and depression at the same time. His COPD March 2021 and hypertension. His the social history, he's married 24 years. His wife passed away last year. He's a current smoker, one pack per day. He occasionally drinks alcohol more in the past weeks than normal because of the holiday season. No illicit drugs, no exercise. His diet has increased calories intake in the last 3 months. He gained weight like 15 pounds in the last 6 months. His history. His father had depression and cardiovascular disease and he deceased. His medication, it's metoprolol succinate 50 milligram daily, fluticasone 100 mcg inhalation twice a day, albuterol 2 puffs every 4 hours as needed for shortness of breath, atorvastatin 80 milligram daily. His OTC medication, aspirin 325 milligram daily. His vaccination, as I mentioned, as Pneumovax 23 and influenza vaccine. He allergic to adhesive. His problem list uh, contain depression that's acute with high priority, COPD chronic with high priority, smoking chronic with high priority, hypertension chronic low priority, high cholesterol chronic low priority, and post myocardial infarction chronic with low priority. I'm gonna move on to assessment of his depression. So according to DSM 5 criteria, Mr. RT meets the criteria for depression. So he has depression mood, diminished interest, more than 5% gain, fatigue, feeling worthlessness and guilt, diminished concentration. So his symptoms present more than 2 weeks period in addition to change from previous functioning. So according to HAM-D score, which is 16, Mr. RT suffered from uncontrolled moderate depression. His risk factor has the family history. His father had depression, major life change, his wife died, serious medical illness, he has MI and COPD, poor social support, he was lonely at his birthday, medication, he on metoprolol, which has 2% risk for depression. Goal of the therapy is gonna be within week 1 improvement in energy, appetite, week 2 to 4 improvement in sadness, attention, and hedonia, week 8 or longer full antidepressant effect. So assessment of his current medication, I see that citalopram is inappropriate for him for 2 reasons. First, Mr. RT was on it before and has kind of side effect he doesn't like, and he want to try a new medication doesn't have this side effects. Second, the QT elevation, and his QT already on 457 millisecond. So I'm gonna move on to my plan for control his depression. So I choose to start Wellbutrin XL 150 milligram BOQAM and may titrate it up according to the response. So maybe after 3 days, increase to 300 milligram once a day. Maximum dose we can reach is 450 milligram per day, given as a single dose. My rationale for my decision is gonna be the SSRI not appropriate because of the sexual dysfunction for all of them, and the QT interval elevation for most of them, and by the patient preferences he doesn't like this class because of the side effect mentioned. SNRI is not appropriate because it has the same side effect of sexual dysfunction in addition to elevation of his blood pressure. The tricyclic antidepressant not appropriate because of side effect tachycardia, weight gain, and sexual dysfunction. Mirtazapine not appropriate because of side effect and weight gain. Nivazoline because of the hepatotoxicity. Trazodone inappropriate because of side effect and sedation. MAO inhibitor inappropriate because of food restriction, drug-drug interaction, and side effect. Vilazodone inappropriate because of side effect, nausea, and diarrhea. Wellbutrin XL 150 milligram would be appropriate because it is the most activating antidepressant. It will help with patient fatigue. It will help with help patient to stop smoking and lose some weight. It does not have the side effects the patient caring about, which is sexual dysfunction and diarrhea. Taking Wellbutrin in the morning, it will avoid insomnia problems. I have non-pharmacological as well, so psychotherapy, CBT, interpersonal psychotherapy, problem solving, therapy, psychodynamic therapy, and physical activity. Monitoring, it's gonna be monitor the side effect, assessing response to therapy. Within 1 week, improvement of energy, appetite, 2 to 4 weeks improvement in sadness, attention, and hedonia, 8 weeks or longer for antidepressant effect. We can modify therapy in case of partial response, which is 25 to 50% response, or no response after initial 4 to 8 weeks of therapy. Patient education: take Wellbutrin in the morning to avoid trouble sleeping. Should be taken at same time each day. Avoid alcohol with drug. Report symptoms of seizure, new or worsening depression, suicidal ideation, unusual behavior change, psychosis, mania, or hypomania. Don't use with other drug to stop smoking and not stop abruptly. I'm gonna move on to his second problem, the COPD. So assessment of disease, it's gonna contain, according to GOLD guidelines 2021, Mr. RT has uncontrolled COPD GOLD 2 Group B because of his FEV1 60% and CAT score 21, which is over 10, with one exacerbation not leading to hospital admission. Risk factor: smoking. Goal of therapy: reduce symptoms, improve exercise tolerance, improve quality of life, reduce risk, prevent progression, prevent and treat exacerbation, and reduce mortality. Assessment of current drug therapy: the fluticasone inhaler 100 milligram, 100 mcg inhalation is inappropriate because no need for using steroid, and it's gonna increase the risk of pneumonia and doesn't match the criteria of eosinophil count. Albuterol 2 buff every 4 hours as needed for shortness of breath is okay as an rescue inhaler as needed. So my plan for Mr. RT, so it's gonna be according to the 2021 Global Initiative for COPD. The recommended medication for Group B are LABA or LAMA, and LAMA in case of patient with severe breathlessness. I recommend starting combination LAMA and LABA, so tiotropium, olodetrol 2.5 mcg, which is a still to Respimat, 2 buff every day, and continue albuterol 2 buffs every 4 hours as needed of shortness of breath. My rationale for my choice is there is no clear evidence that one agent of LAMA class is better than another, so I pick the tiotropium. Combination of LAMA and LABA improves FEV1 and symptoms, which is evidence 1, and reduce exacerbation with evidence B. And or CAT score over 20 better than monotherapy, and my patient has a CAT score of 21. In patient who complains of dyspnea or exercise intolerance as Mr. RT, recommended LABA and LAMA over monotherapy. Because of the eosinophil count is 50, so no need to use inhaled corticosteroid. Because of the patient doesn't have a history of asthma as well, there is no need to use inhaled corticosteroid. Inhaled corticosteroid increase the risk of pneumonia and have reduced benefit with patient currently smoking. Delaresp inappropriate because inhaled therapy not maximized yet and because of the side effect, depression and diarrhea. Oral azithromycin inappropriate because not recommended by guidelines and in addition to the QT elevation. My non-pharmacology is gonna stop smoking, pulmonary rehabilitation, and oxygen. Vaccination, I recommend COVID vaccine, Brevinar 13 at 65, and 1 year later it's gonna be Pneumovax again. Patient education, proper inhaler technique and cleaning, smoking cessation, monitoring, symptoms relief, improve exercise tolerance, improve quality of life, FEV1 ratio with FBC, CAT score, MMRC grade, and exacerbation. I leave couple of references in my page if you want to have a look on them. And thank you and have a great day. Bye.